Hello, everyone. Good afternoon, good morning, wherever you are joining us. Thank you so much for joining us today. Welcome to the episode 9 of MSGERC Grand Round series. And today we'll be discussing about combating antifungal resistance in the hospital setting. So, as you all know, I know that I'm preaching to the choir here. Invasive fungal infections are on the rise worldwide with the growing emergence of resistant fungal organisms. The emergence of novel fungal variants that were previously susceptible is a matter of concern. This problem is compounded by the problem of poor sensitivity, limited availability, and increased turnaround times of existing diagnostic tests. Additionally, the arsenal of antifungal medications are not that great, leading into limited options. At the same time, the prescribing providers may not be aware or less familiar with appropriate indications for choosing antifungal medications, underscoring the needs for enhanced antifungal prescribing practices in the hospital setting. In this webinar, we will discuss the core principles of antifungal stewardship as provided by the 2020 guidance document, and we'll address some of the emerging challenges in the management of invasive fungal infections in the hospital setting. My name is Dr. Teny M. I'm one of the infectious disease faculty assistant professor in infectious disease at MD Anderson Cancer Center. And I have a special interest in this topic because I'm working on incorporating antifungal stewardship into our antimicrobial stewardship practice here. And in this webinar, we are bringing experts from public health experts from CDC and Dr. Peter Pappas for this group discussion. And we are extremely pleased to have Dr. Peter Pappas as our clinical expert in this webinar. Thank you so much, Dr. Pappas, for joining us today. He's an emeritus professor of infectious disease at University of Alabama in Birmingham and is chair of the scientific committee of MSGERC. Dr. Pappas helped to establish antifungal stewardship in his institution, and so we are excited to learn from him about his experience in initiating that. Next slide, please. We are also thrilled to be joined by our esteemed colleagues from Center for Disease Control from the Mycotic Disease Branch, Dr. Dallas Smith. He's an epidemiologist, and he'll be discussing about the core elements of antifungal stewardship. Dr. Jeremy Gold, he's a medical officer in the same branch, and he'll be looking at discussing about perspectives of resistant aspergillosis. And Dr. Sophie John-Salen, who's also an epidemiologist, will be giving an overview about resistant Candida species. In terms of our agenda for the meeting, this is a broad overview. We'll spend initial 35 minutes listening to the public health experts from CDC on these topics, followed by there'll be questions to Dr. Pappas and the panelists on incorporating antifungal stewardship into antimicrobial stewardship programs, followed by question and answers from the audience. So this educational initiative is part of a cooperative agreement from CDC to University of Alabama in collaboration with MSGERC and Terra Nova Medica, and the details are shown on the slide. A couple of housekeeping points. There will be a polling question at the end. Again, during the course of the meeting, please select your answer and the results will be displayed. You will be muted throughout the webinar, and you have an opportunity to ask questions in the Q&A session in the chat box. Please ask your questions there, and we will try to get to these questions as many as possible. And the contents will be archived in the funguseducationhub.org website afterwards. So without further ado, I'll now turn over to Dr. Dallas Smith, who will share the perspectives on antifungal resistance and stewardship. And Dallas, the floor is yours. Thank you.
Thank you so much, Dr. John. Next slide, please. And so before we could get into antifungal stewardship and what it really entails, I just want to talk briefly about the rise of antifungal resistance, which many of you are aware of. Next slide, please. And so over the last decade and even beforehand, several fungi have developed resistance domestically and globally. And some of the big ones that we think about in terms of high levels of resistance or emerging resistance include Aspergillus, Candida, and specifically Candida auris, and also ringworm. Next slide, please. And when we think about domestic and global threats, this is a huge threat for both immunocompetent and immunocompromised individuals. And so I just wanted to put up a few media articles that are really highlighting just how big of a problem this is globally. And so we see that these big news organizations are picking up on the threat of antifungal resistance, and it's becoming, of course, a problem for clinicians and researchers, but also a problem for the public that they're really starting to pay attention to. Next slide, please. And as Dr. John mentioned, we only have a few antifungal classes available to us, and unfortunately, we have seen resistance develop in almost all these classes of antifungals, and so we're really running out of options. And so it's important that we really highlight and utilize stewardship to protect these classes, and also protect new and novel classes that hopefully will be approved soon for the use of fungal infections. Next slide, please. And so a lot of you are probably wondering, what is antifungal stewardship? Is it different than antimicrobial stewardship? Is it a part of antimicrobial stewardship? So I want to spend these next maybe 5-6 minutes just talking about the basics and core elements of antifungal stewardship and how we can use that to address antifungal resistance. Next slide, please. And so most of the content that I'll be talking about in the next couple of minutes is really taken from the core recommendations for antifungal stewardship that was developed and published by the Mycoses Study Group Education and Research Consortium, or MSG as we all are commonly know it as. But really the broad focus is that antifungal stewardship should be a part of essential antimicrobial stewardship. So it should be part of those programs at facility and healthcare systems level. Next slide, please. And so now I'm going to go over the core elements that MSG has laid out for antifungal stewardship. The first one is that we need to engage senior leaders in hospitals and in healthcare systems. We want to integrate antifungal stewardship into strategic plans and policies, and making sure that these senior leaders are paying attention to antifungal stewardship, have that on board, and making sure that we have their buy-in so that we can really fulfill some of the different actions that are needed for antifungal stewardship. And also we need the resources to do it so. And so we need our senior health leaders on board. Next slide, please. And so core element 2 is that we need people who are accountable and responsible for antifungal stewardship. And that does require in-depth knowledge and clinical experience in the management of invasive fungal diseases. And this could be a variety of things. And so we want individuals who are familiar with fungal epidemiology and susceptibility patterns. We want to make sure that they are doing the right diagnostic tests and how to interpret diagnostic tests. We want people who are passionate about fungal surveillance, and then also utilizing all of these actions to make sure that we're giving the appropriate therapy. And some collaborative experiences that is recommended in the MSG core elements, and this is core element 2, is that we want to engage key practitioners who would be treating patients with fungal diseases. And ways that we can reach those individuals is through weekly clinical rounds that people already probably have for antimicrobial stewardship, making sure we're also talking about antifungal stewardship in those clinical rounds. Next slide, please. So core element 3 is available expertise on infection management. And this really goes down to kind of diagnostics and being able to interpret those diagnostic results. And so what core element 3 really, if you get down to it, one of the things they recommend is that we need timely conventional, so that microscopes, histopathology, culture-based, and non-culture-based diagnostic testing, especially for some of our big fungal players like Candida species and Aspergillus species. So kind of transitioning to the core element number 4, highlights education and practical training. And so we want to make sure we develop targeted educational programs. As part of this multifaceted stewardship approach to address knowledge gaps. And this can be yearly training, this can be onboarding training, and probably a mixture of both, because we're always learning new things about fungal diseases, and that plays into how we practice stewardship. Next slide, please. And so core element number 5 is looking at other actions aiming at responsible antimicrobial use. And so we want to make sure we're looping in our infectious disease physicians as much as possible. We want to make sure we're consulting with them, and including those include infectious disease pharmacists as well. We want to make sure that we develop at an institutional level care pathways or treatment guidelines of sorts that clinicians can follow when they diagnose a fungal disease. Other things that we could be doing, that's making sure we're using antifungals correctly, is ongoing interventions such as handshake stewardship rounds. So making sure that when we're passing off patients to the next the next clinician, we're making sure we're talking about what antifungals they're on and what is needed going forward. And also, we want to make sure that we're kind of doing surveillance and making sure we're evaluating the quality of antifungal prescribing, not on an ad hoc basis, but on a routine basis, a systematic basis, and so that we know what our prescribing patterns are like for antifungals and if we need to intervene. Next slide, please. And so I mentioned monitoring and surveillance a little bit so far, but core element 6 really focuses on these aspects of antifungal stewardship. And so we need local surveillance systems for fungal infections, just the epidemiology of what's occurring in facilities. And this will really support antifungal stewardship programs at a facility level instead of just looking nationally. One of the other things that is really important, and I think my colleagues will touch upon this, is timely antifungal susceptibility testing, especially for Candida species and Aspergillus species, because that can guide treatments, which is really important if we want to get the best outcomes for patients. And then, so results of both fungal culture and non-culture based tests should be communicated to antimicrobial stewardship teams, so those individuals can intervene in the real time. There shouldn't be a retrospective notification. It should be real time so that we can intervene when a patient is in a critical condition. Next slide, please. And so just a little more on monitoring and surveillance. We want to make sure that patients have their medication records screened by a clinical pharmacist or even a clinician to carefully assess for antifungal drug interactions. Especially, for example, our azoles have a lot of drug-drug interactions, and that plays into how we practice stewardship, because we don't want those interactions causing adherence issues or causing pharmacokinetic issues. And also, one of the important things that we'll talk about throughout the rest of this presentation is access to antifungal therapeutic drug monitoring, especially for azoles. These drugs have narrow therapeutic windows, they have absorption issues, and so we want to make sure we're getting the right amount of drug in the blood, and so access to therapeutic drug monitoring is critical for this. Next slide, please. And finally, our last core element is reporting and feedback. So we want to make sure we have mechanisms to track antifungal drug use and making sure we're reporting back to clinicians, to pharmacists, and not just keeping that at maybe the hospital epi level. We want to benchmark antifungal use so that we can see trends over time. We want to assess patient-level outcomes where possible to see if our interventions are working. Also, as I mentioned, we want a mechanism for direct data feedback to prescribers. Those are the ones on the front lines treating patients. Next slide, please. And so those are the 7 core elements that MSG laid out. I think they did a really good job kind of describing what antifungal stewardship can look like. I just want to briefly mention CDC's and our branch's antifungal stewardship priorities. And so we want to look at the right diagnosis. We want to make sure we are increasing access to highly sensitive, non-culture-based diagnostic tests with a quick turnaround time, which that is always kind of the key, making sure we get results back in a timely manner. We want access to infectious disease specialists. And one other thing that we won't touch upon a ton today, but we also want to make sure we're giving prophylaxis, antifungal prophylaxis in appropriate situations and to appropriate patients. We want to make sure we're using the right drug. And so can we utilize antiobiograms and antifungal susceptibility testing? We also want to promote the establishment of epidemiological cutoffs. Breakpoints are hard to come by with fungi just because they're a little less common than some of our bacteria or viruses. But we can utilize ECVs in order to look at rising rates of MICs or potential antifungal resistance. We want to invest in novel antifungal classes, which we have a few promising candidates coming onto the market hopefully soon. And also access to antifungals for vulnerable populations and making sure they're affordable and accessible. Also, for the right drug, we want to make sure we're giving appropriate empiric therapy, especially for candidiasis, making sure we're looking at susceptibility trends and making sure that we're probably utilizing maybe our kind of candins instead of fluconazole for empiric therapy. And then finally, we want the right dose, right level of drug in the blood. And so we want to look at therapeutic drug monitoring and also looking at drug-drug interactions. Next slide, please. And so before I turn it over to my colleagues to talk about specific fungal diseases, we want to go through two polling questions. And so polling question hopefully is popping up on your screen. But the first polling question is, what healthcare setting do you work in? A, academic medical center. B, community affiliate of an academic medical center. C, community hospital, medium to large. D, community hospital, small. E, government funded hospital, for example, like a VA hospital. Or F, other. So I'll give you about a minute or so just to answer that polling question real quick. All right, maybe about 30 more seconds. I still see a few votes coming in. All right, for time's sake, I think we'll transition to the next polling question. And so our next polling question is, we're really curious about what antifungal stewardship activities are you doing at your facility? And so our question is, do you have antifungal stewardship at your institution, also abbreviated AFS? And if so, we're curious about what components of AFS do you have? And so I won't read all of these answer choices out just because they're pretty long, but we would love to see what kind of AFS or what antifungal stewardship activities you have going on at your facility. And so I'll give you maybe a couple minutes just to kind of answer this. I see lots of people are voting currently. All right, just maybe 30 more seconds. I see we almost have about 30 votes, and so I'll give it 30 more seconds to see if we can get just a few more. Okay, all right. Well, thank you all so much for answering these two polling questions. I will now turn it over to my colleague, Dr. Jeremy Gold, to talk about azole-resistant aspergillosis.
All right. Thank you so much, Dallas. That was great. And thank you all for this opportunity to speak with you about azole-resistant aspergillosis. Next slide, please. So just a little bit of brief background about aspergillosis in general. I just wanted to highlight that, even though invasive aspergillosis is considered uncommon, it still carries a really substantial burden in the United States on patients and the healthcare system. Just some quick stats, there are over 14,000 US hospitalizations per year that are associated with invasive aspergillosis, $1.2 billion in direct costs, in many instances, nearly 50% mortality rate, and there were about 1,200 US deaths in 2021 attributed to aspergillosis. So it's we all know that this infection is no joke, and we also think these are kind of substantial underestimates given how frequently aspergillosis is a missed diagnosis, particularly in ICU patients. Next slide. Thanks. And of course, azole antifungal drugs like voriconazole have really changed the game in terms of treatment for invasive aspergillosis. Their azoles are considered the first line drug, and they've been associated with really a much greater survival compared with when we were in the pre-azole era and had to rely mostly on amphotericin. Next slide, please. And one of our, big concerns at CDC is the ever-expanding population of patients who are at risk for invasive aspergillosis, whether resistant or not. And this relates to the growing number of patients who are receiving immunosuppressive drugs, particularly like the SMKI drugs and the TNF-alpha inhibitors. We also observed a substantial uptick in aspergillosis during the COVID pandemic. And we believe that aspergillosis is likely underdiagnosed, as I mentioned, particularly in patients with COPD, asthma, and those taking steroids. We see a lot of aspergillosis in sort of non-classic patient populations. Next slide. And since so azole-resistant aspergillus infections have been a problem, or have been recognized as a problem since as early as the 1990s. And back then, most of the cases of azole-resistant aspergillus infections occurred in patients who had chronic pulmonary aspergillosis and were receiving azole therapy kind of intermittently for years. And that type of resistance was so basically like the resistance was developing an aspergillus in the lungs of those patients because of frequent selective pressure from frequent use of azoles. And when azole resistance is selected for in that manner, it's generally been associated with single amino acid mutations in the CYP51A gene. And I only point that out because I'm going to talk a little bit more about environmental fungicide use associated resistance, which tends to have different markers of different genetic markers and mutations that confer resistance. Next slide, please. And unfortunately, when we're talking about azole-resistant aspergillosis and aspergillosis, it's sort of taking us back to that pre-azole era in terms of mortality. One of the largest observational studies that that's come out was in CID by Lestrade et al. And basically, what they saw that when comparing patients they compared patients who had azole-resistant aspergillosis versus those with azole susceptible aspergillosis, and they found that those with resistant strains had a 33% worse survival rate compared with those who had susceptible isolates. And some smaller studies have actually found higher mortality rates associated with azole resistance, but this is one of the larger studies I've seen out there. So I just wanted to point that out. Next slide, please. And one of the troubles that we have with assessing the scope of this problem really has to do with the lack of data on azole-resistant aspergillosis in the United States. Currently, there's really only testing available at select laboratories, and that includes CDC's AR lab network. We always want to make a plug for that there is free testing available for Aspergillus fumigatus isolates through the AR lab network. But based on the limited, there are some limited data available on the scope of this issue in the United States. And one of the largest studies was a 2015 to 2020 study done at a major fungal reference laboratory, the University of Texas San Antonio Center. And they found that they tested over 2,000 A. fumigatus isolates, and about 3 to 5% were resistant to one or more extended spectrum azoles, including voriconazole, savuconazole, or posaconazole. And we're really it'd be very helpful. We're very interested in kind of gathering more systematically collected data to really assess like what the prevalence and clinical implications of azole resistance in the United States for Aspergillus. But in the meantime, we're also very concerned about the potential for increase in resistance due to environmental azole fungicide use. I won't go into every detail, but basically the use of azole fungicides in the environment can select for Aspergillus fumigatus outdoors. That is, it basically can select for azole resistance, which is different from the kind of the way that resistance develops in patients with chronic pulmonary aspergillosis. Next slide, please. And just to point out, the reason we're so concerned about the environmental fungicide issue is that in the United States, there's been a substantial increase, really a fourfold increase in the number of metric tons of azole fungicide use in the environment in agricultural settings. And next slide, please. So Europe, particularly the Netherlands, where they have a large tulip industry that uses happens to use a lot of azole fungicides. The Netherlands was really identified as the first hotspot, but now there have been cases of azole-resistant aspergillosis observed across the world, and these are isolates that have mutations that are specifically specifically are linked to the use of environmental fungicides. And next slide. And now actually we will do a polling question. So I guess this is not our first rodeo with this now, but the question is, do you request antifungal susceptibility testing or AFST for Aspergillus fumigatus? And if so, where do you send isolates? So the options are that you do not request AFST testing for Aspergillus fumigatus, that you do and the testing is done in-house, that it's a commercial laboratory send out. D would be an academic university laboratory send out, and E would be the AR lab network. So I'll give people like, a minute to think about that. So it looks like a plurality of people do. Oh, now the numbers are changing. Okay, I'll wait. I will not close too early on this. I will wait until people finish answering. Give it a little more time. All right. And keeping in mind, of course, that not the audience here may be groups that are particularly interested in antifungal resistance. So results may vary, across the country. It looks like about a third of respondents do not request AFSC testing for A. fumigatus. A small percentage, 6%, have the testing in-house, and kind of the remainder, like 16 to 22%, it's either commercial send out, academic send out, or AR lab network. And with that, to keep things moving along, I'll pass it on to my colleague, Sophie. Thank you so much for your attention.
Thank you, Jeremy, and hi, everyone. Thank you for the opportunity to talk to you guys today. So now I'm actually going to change direction slightly, and I'm going to talk about emergence of new resistant Candida species. Next slide, please. So we often hear about the threat of Candida auris, which CDC classifies as an urgent threat that requires urgent and aggressive action. But it's really important to note that there are other drug-resistant Candida which are classified as a serious threat. And drug-resistant Candida are one of the most common causes of healthcare-associated central line-associated bloodstream infections. So today I'm just going to briefly talk about a couple of non-C. auris species. Next slide, please. So Candida infections are typically the result of 5 main species: Candida albicans, Candida glabrata, Candida parapsilosis, Candida tropicalis, and Candida krusei. And really what I want to point out here is that we've seen this recent shift in the species distribution among these Candida infections. So in the past decades, Candida albicans comprised over 50% of all candidemia. However, the non-albicans Candida species are being encountered more frequently as human pathogens, and in some cases, non-albicans Candida species are being encountered more frequently than Candida albicans. Next slide, please. So why is species identification important? So it's important to note that some species have greater or worsening resistance to antifungal drugs. So for example, Candida krusei has intrinsic resistance, Candida glabrata has reduced susceptibility to azoles, and Candida parapsilosis has reduced susceptibility to echinocandins. Next slide, please. So due to increasing resistance to fluconazole, the Infectious Disease Society of America updated guidance in 2016 to recommend use of echinocandins as the first-line therapy for all invasive candidiasis. And this also came with a recommendation to step down to fluconazole after 5 to 7 days if the isolate is susceptible. So to better explain this, and put it into a bit of perspective, over 98% of all US Candida albicans isolates have been susceptible to fluconazole over the past few decades. Therefore, patients with invasive C. albicans infections can safely be transitioned from echinocandins, which is the first-line treatment recommendation, down to fluconazole in most situations once the species has been determined. So in this situation, you would want to do that step down. But in contrast, there's about 10 to 12% of Candida glabrata isolates are resistant to fluconazole, and resistance can develop with treatment. So this would make echinocandins the treatment choice for most C. glabrata infections until that susceptibility testing has been done. And the ability to do the step-down therapy can be really helpful to prevent unnecessary use of echinocandins and preserve those drugs as options for future treatments and also reduce the cost of therapy. Next slide, please. So to assess the appropriateness of treatment practices and the adherence to these updated guidelines, our team led an investigation to look at the treatment practices among patients who had candidemia, and these were identified through CDC's Emerging Infections Program from 2017 through to 2018. So even with that guideline update to recommend use of echinocandins, it was found that among 1,835 patients within the surveillance area, 30% still received fluconazole as their initial treatment, but over half of them were infected with a non-albicans species. And for those isolates that underwent antifungal susceptibility testing, 10% were resistant to fluconazole. So this indicates potentially inappropriate treatment for those patients with non-albicans species or with the fluconazole-resistant species, indicating non-adherence to the ISDA updated guideline. Next slide, please. Okay, so I'll now very briefly talk about two investigations which are summarizing interesting drug resistance patterns that we've seen recently. So I'll start with increasing incidence of fluconazole-resistant Candida parapsilosis bloodstream infections. Next slide, please. So Candida parapsilosis is a leading cause of invasive candidiasis, and it's found across many geographic locations as shown in the map on this slide. And resistance to fluconazole has been linked to a mutation in the ERG11 gene. And candidemia surveillance is performed through the EIP program, which captures data for 10 states. And back in 2021, routine testing picked up an increase in fluconazole-resistant bloodstream infections in Georgia. Next slide, please. So I'm not going to go through this table in a lot of detail, but what the study did was examine differences between patients who had susceptible isolates versus resistant isolates. And some significant differences were noted. So, for example, resistant isolates were more common among patients who had been admitted to a long-term acute care hospital in the past 90 days, and less common among patients who were admitted to an acute care hospital. So a social network analysis was done to look at the movement of patients, and that indicated that 2 LTACs in particular were associated with the resistant isolates. Next slide, please. So the key takeaways of this are that firstly, in Georgia, the number of azole-resistant infections almost doubled between 2020 through to 2021. And all resistant isolates were found to be very closely related and were associated with exposure to these 2 LTACs. So while some patients developed resistance following treatment with azoles, others didn't receive azoles. And so for those, it was suspected that there was transmission of a resistant strain that had contaminated the environment, similar to what we see with Candida auris. And this is important because excluding Candida auris, most Candida bloodstream infections are not spread from patient to patient, and typically people will get it from their own flora. So this indicates possible changing epidemiology of Candida parapsilosis, and then also shows this increase in the number of resistant infections. So this really highlights the importance of doing antifungal susceptibility testing to guide those treatment therapy decisions. Okay, so next slide, please. I'll now very briefly talk about an investigation that looked at acquired fluconazole resistance and echinocandin resistance in patients with serial Candida glabrata infections. Next slide, please. So Candida glabrata is an opportunistic pathogen that's become the second most common cause of invasive candidiasis in the US. And previous studies have demonstrated the emergence of fluconazole or echinocandin resistance in response to treatment. And in vitro studies have shown acquisition of multi-drug resistance. So similar to parapsilosis, surveillance of candidemia caused by Candida glabrata is performed through the Emerging Infections Program. Next slide, please. So a retrospective analysis was performed of serially collected clinical isolates among patients who had more than one case of candidemia identified through EIP. And the aim of the analysis was to evaluate antifungal resistance that had been acquired during treatment. And then whole genome sequencing was used to describe the relationship between resistant and susceptible isolates taken from the same patient to explore acquisition of resistance in response to that original treatment. So overall, there were 33 patients who were identified who had between 2 to 5 isolates collected over time. Next slide, please. So using whole genome sequencing data, the authors identified that 96 single nucleotide polymorphisms was identified as this cutoff value to determine if the strains were the same or not. An identification of this cutoff value allowed the authors to determine that Candida glabrata acquired resistance during patient treatment. And this resistance was largely in line with the patient's original treatment. So for example, the patients who've been treated with fluconazole had strains that then went on to develop resistance to fluconazole. And the same was found for patients who were treated with echinocandins. So importantly, what this shows is that Candida glabrata can really rapidly acquire resistance to antifungals, which again highlights the importance of antifungal stewardship. Next slide, please. And we just want to thank you for your time today and for inviting us here to speak. Thank you.
Thank you, Jeremy, Dallas, and Sophie. Excellent discussion of very, very important topics. So I think we will proceed to the Q&A session. Before, again, I'll ask Dr. Pappas and the panelists some questions relating to incorporating antifungal stewardship. Before that, I encourage all the participants who have joined us online, please post your questions in the Q&A chat box, and we'll be happy to answer any question. Again, every question is important, especially in this area where we are trying to develop and make it more common practice in our day-to-day clinical care. If I may ask, Dr. Pappas, in terms, before going into the specific details of antifungal stewardship, the big question that comes up is how is antifungal stewardship different? Again, we know that it's an extension of antimicrobial stewardship, but what are the fundamental differences between antifungal stewardship and antimicrobial stewardship that should prompt institutions to take it seriously?
Yeah, that's a good question. And it is it's a continuum. They're not really separate, but the approach is perhaps somewhat different. I think in antibacterial stewardship, let me say this, there are similarities and some differences, but with any microbial or antibacterial stewardship, we kind of like to select workhorse agents, and we have enough agents that, we'll select 5 or 6 agents that you can obtain without any approval. And then if you want to escalate, for instance, in our hospital, if you want to get meropenem, you have to ask permission or have an ESBL producing organism in hand or a recent history of that. So it's really, pretty restrictive, but within the allowable drugs, there's really no questions asked. I think with antifungal stewardship, outside of fluconazole and perhaps the echinocandins, our restrictions are significantly greater, and for obvious reasons. I think that there's toxicity, there's concern of overuse, a lot of drug-drug interactions, et cetera. A lot more challenges, it seems to me, with some of the antifungals, and so of course we have fewer of those. And when you run out of options with antifungals, you haven't gone through a whole litany of agents. It's usually 1 or 2, and if those key agents are no longer effective, then you may not have a treatable organism. So I think, in truth, there are similarities, probably more than there are differences, but I think the differences probably stem from the fact that there are fewer choices. And we allow a little less leeway with kind of the workhorse agents, which, in most hospitals are going to be fluconazole and an echinocandin. And then everything else is, I think, potentially something that you would look at and scrutinize and maybe even have a phone call to release it.
Thank you, Dr. Pappas, for that answer. Again, very useful. Again, I don't know whether the other panelists have any additional comments in terms of how they see antifungal stewardship differently.
Hi, Dr. John. Yeah, I think it's an incredibly important question, and I agree with Dr. Pappas that it's really just an extension of antimicrobial stewardship. But as Dr. Pappas mentioned, there's a lot of baggage that a lot of our antifungals carry, and so I think we need to be thinking a little more about how we can be good stewards of those medications. I think we have to do a really good job of assessing drug-drug interactions, of assessing just the pharmacokinetic problems that many of our antifungals have, especially the azoles, which are commonly used. And one of the things that is really important is trying to set up therapeutic drug monitoring for our azoles and making sure there's a system in place to get results back in a timely manner, just to make sure we're getting the right amount of drug in the blood, because that can really improve outcomes and also prevent toxicity if we have too much drug in the blood. The other thing is just making sure that we're treating empiric candidiasis correctly. I think that's a really easy key stewardship intervention. Thinking about utilizing the candidiasis guidelines by IDSA, making sure we're really going with the echinocandins first, and then if we get susceptibility results back, then we can back off and maybe give an azole. But I do agree with Dr. Pappas that it's an extension of antimicrobial stewardship, but something we've neglected nationally for quite some time now.
And in that regard, I think it is important to have the institutional guidelines also, right? Again, Sophie very well mentioned about the IDSA guideline. People are more familiar with antibacterial use in terms of when to use it, how long to use it, but there's not so much of guidance. There is guidance, but again, the patient complexity is so intense that sometimes it's hard to kind of, again, there should be institutional specific guidelines to treat these infections that makes the antifungal usage more challenging. Any additional thoughts, Sophie, Jeremy?
The
Yeah.
No, the other thing I just wanted to mention is that a key and quick and really sustainable stewardship intervention for antifungals is just making sure that we have specific fungal disease education and stewardship implemented in our healthcare systems and facilities. We recently did some focus group discussions on some of our dimorphic fungal diseases like coccidioidomycosis, histoplasmosis, and blastomycosis, and many of our focus group panelists who were ID physicians, pharmacists, had never heard of those diseases. And they're really important causes of community-acquired pneumonia. And so just being able to give that education on a yearly basis or maybe a more frequent basis, just to remind people that to think fungus in a variety of clinical presentations, whether that be a community-acquired pneumonia, whether that be sepsis, just making sure we're always thinking fungus so we can care for patients properly. But I'll turn it over to Pete.
As I was listening to some of the other comments, one of the great misunderstandings, I think, is that fluconazole and the echinocandins are equivalent against susceptible organisms, and perhaps they are. However, the studies that have been done, the randomized control studies of candidemia, have indicated that, in fact, the echinocandins are associated with better outcomes independent of fluconazole susceptibility. So there's good reason why we use echinocandins up front. And that is that, they lead to better outcomes in terms of overall mortality. And while it's impossible to say with certainty why that is, you have to believe it has something to do with sidality and early sidality. The other comment I was going to make before perhaps when we move on is so much of mycology is wrapped up in candidiasis. They're probably, I think the data suggests that candidiasis is about 10 times more common than anything that comes in second, especially like the endemics or invasive mold disease. And I think it's important that our efforts kind of do focus on that, because that's where all the usage is. So you were asking earlier about some of the differences, and I think one of the big differences, doesn't occur in our hospital, but it does occur in many places, is that you go into an ICU, and in order to prevent candidiasis, you are, as part of their power plan, fluconazole is administered. So it's I think a gross overuse of the compound in a general ICU type of setting. Of course, there are cancer patients and other groups that might benefit from that approach, but it's never been really shown to be an effective or cost-effective approach in the general ICU population. And so that's just another area where we see antifungals used almost before antibacterials, just by virtue of the fact that they're perceived to be at risk for a difficult to diagnose disease sometimes.
Thank you, Dr. Pappas. I think that's a very valuable point in terms of using echinocandin upfront in sick patients. So now we'll get some of the audience question answered. Vishal Gupta is asking in terms of what is the suspicion of azole-resistant aspergillosis, and what are the indication of it clinically? Maybe Jeremy, if you could answer that, and maybe we'll get additional thoughts from the panelists.
Sure. I'm sorry. Was that there were two questions. Was that the one of the prevalence or the
No,
clinical presence?
the question is about suspicion of
Oh, okay. I can
Aspergillosis.
start, but Pete, Dr. Pappas might be able to give a more detailed question, but I'm not aware of like a lot of data about the specific clinical differences between azole resistant and azole susceptible Aspergillus fumigatus, other than the response obviously to azoles. I don't know if I have any other like clinical pearls or hints related to how you would know, other than just the patient not getting better as you might expect with an azole. But I don't know, Pete, if you might have.
I think
you're more in the game
yeah.
than I am.
Well, yeah, I mean, I think that this is a question we ask all the time. And one of the shortcomings is that we don't do, most hospitals do not have access to, rapid turnaround AFST among their molds. We do for Candida. So within 48 hours, we usually have a susceptibility panel, but not so for the molds. And so in our situation, which is, I think probably pretty common even among academic centers, it's a matter of, okay, we have Aspergillus, we have grown it, which nowadays is somewhat unusual because as Teny can attest to, most cases of aspergillosis are not culture-based. And so what makes this even more difficult is that you're dealing with a clinical situation based on serologic or non-culture-based diagnostics, and you're trying to make therapeutic decisions that are not based on susceptibility. So if one were to ask, what are the characteristics of a person with azole-resistant aspergillosis, and I would say it's poor response or lack of response to what should be effective antifungal therapy. I don't know any other specific characteristics epidemiologically or travel, et cetera. It seems to be a relatively random event. Fortunately, in the U.S., it occurs seemingly less than 5% of the time. However, in the Netherlands, if you believe their data, 20 to 25% of the time. And so they have a very low threshold for transitioning from primary azole therapy to amphotericin plus minus and echinocandin. So, it's tough. And so unlike Canada, where our diagnoses usually rest on a positive culture or a histopath, with Aspergillus, it's really just the opposite. It's very serologically driven. And I would ask Teny, do you see that any differently?
Yeah, no, absolutely. I think you touched upon it nicely. So one other aspect that may be kind of difficult to kind of predict whether it's resistant is the host factor, right? Because we know, like, again, despite treating them heavily with triple antifungal or double antifungal with an ambisome-based regimen, we see sometimes no response. Maybe that's mostly related to a host problem, like a relapsed refractory AML patient, with zero neutrophils and like a worsening cancer. So that also add the complexity to the question in terms of predicting azole resistance. And then when I was listening to Jeremy, like, again, even in our invasive aspergillosis patients, we tend to treat for many months, and during the course of the treatment, they may develop a resistance, right? So it's very hard to, and as Dr. Pappas rightly mentioned, it's, again, these progression or breakthrough are mainly based on antigenemias and not based on culture. So it is very difficult to say whether this is we are dealing with a resistant infection unless we have something grown in culture. Yeah. So again, there are two questions. Maybe I can ask Jeremy again. Thanks, Vishal, for asking the previous question from Emily and Joseph in terms of what is the prevalence of resistant aspergillus in the US. Jeremy, I think you
Sure. Yeah. I mean, the short answer, yeah, I'm happy to answer that one. And the short answer is we don't know. I think, like Pete mentioned, Dr. Pappas mentioned, there is that one study showing like a prevalence of maybe up to 5% of azole-resistant aspergillosis, but it was a really well done study, and it was a big study, but it was definitely not representative. It was, at a fungal reference laboratory. So what's really happening, like in the general population of patients who have aspergillosis, we don't know. And I think it's just an important area where research is really needed to kind of determine the prevalence, get a better estimate of the prevalence of Aspergillus, of resistant Aspergillus fumigatus infections, and also to better understand sort of the optimal, the clinical implications and the optimal treatment for patients with resistant strains. It's a big knowledge gap that our CDC is very interested in addressing. But the answer is we don't know. We're concerned. We don't know what the baseline is, but we need to figure that out, and we're concerned that the proportion could increase.
Thank you. And again, thank you for that answer, and thank you for asking that question. So we have another question from Gargi Patel in terms of, is there any guidance on supporting stewardship interventions for antifungal prophylaxis used in immunocompromised patients that could be niche to expand on increasing antifungal resistance? Dr. Pappas, you would like to answer?
Sure. I'll give this up. Is there any guidance? I think that like so many other things in clinical mycology, we just don't have the volume to generate lots of really strong data-driven recommendations. But I think that there is a concentrated group of individuals, and I would say, these are mostly patients with, from oncology centers. So they're stem cell transplants and people with hematologic malignancies that are not transplant recipients, where there are data. It's oftentimes single center, not oftentimes huge, large, multi-center studies. But I would say let's talk about two groups, because this is where I think there are data. One is, that group, the stems and the hematologic malignancies. And then on the other hand, we've got the solid organ transplant recipients. We can handle the solid organ transplant recipients pretty easily. And the one group where antifungals have been absolutely shown to have a impact is prevention of Candida and high-risk liver transplant recipients. And those are defined as the type of anastomosis, choledochia, jejunostomy, pre-existing renal function, duration of surgery, et cetera. If you meet criteria for high risk, then you benefit from anti-Candida prophylaxis within the first 10 to 14 days. It's difficult to find similar data in other solid organ transplants. And where that data is mostly needed is in the lung transplant population, but that horse has left the barn. Everybody uses mold active agents. And so getting people to stop that and give potentially a placebo is going to be really tough. That's not going to happen. Mm-hmm. So we do the best we can. I think with the stems, we have a little bit better data. We know that if a person is at risk for GVHD, that it is reasonable based on data to provide any mold prophylaxis. And when they start GVHD prophylaxis with cyclosporin and or steroids or some other combination, then starting with mold prophylaxis seems to be standard. It's based on some data. It's not like the greatest data in the world, but it's strong enough that it's an acceptable practice, and most centers, as you can attest to, would adhere to that. What varies is, well, I really prefer voriconazole, or I prefer Posa, or I prefer even a savuconazole, but that's very much driven by your perception of the risk of mucor, your concern about drug-drug interactions. Isavuconazole has fewer, perhaps, than some of the others, and some of those are really unique to the transplant population and the hematologic malignancy population. So there are niches like that where antifungal prophylaxis is warranted. It's in guidelines. I would argue that most of the data are based on smaller studies. And I'm talking too long because we're going to run out of time here, so I'll shut up. But,
no problem. That's again, you touched upon all the relevant points, and also we know that the number of expanding indications are increasing, especially in the cancer world with the newer therapies. There is this curve going up, and then it's important to have, again, underscoring the importance of institutional algorithms in antifungal prophylaxis that may help with antifungal resistance.
I think so. Many of these decisions are driven by. We've had 4 cases of mucor in the last year in our institution. Ergo, we're going to use posaconazole in all of our stem cell transplants. And then there's a lot of that anecdotalism that goes on that may or may not be necessary and applicable to all centers.
Yeah, absolutely. Thank you, Dr. Pappas. I think we are at the top of our hour here, and we want to thank all the participants. Again, first of all, thank all the panelists for their expert opinions and presenting the important perspectives. We want to thank our audience for being here and asking relevant questions. And for those who have missed this webinar, it will be available in the archive form at the funguseducationhub.org in a few days. And we also want to encourage you to pursue these offerings from MSGERC on Candida auris, and the link is given in the slide, and you can sign up for the future webinars as part of this series. Again, I want to thank all my colleagues and the panelists for being here, and the audience for their contribution, and I want to wish you a very nice day, and see you all soon. Bye-bye.